Any idea about what symptoms patient present with acute limb ischemia? Paresthesias, pulselessness, cold, very good. Perishing cold, swollen, I will, okay, or discoloration, very good. Paralysis, very good. So there are 5 P's. Pain, which is very severe. Patient have felt pain, first time so much pain in their life. Then it will be perishing cold. They have the poikilothermia. There may be paresthesia. There may be paralysis. And very important, pulselessness. There is loss of pulses. And any idea what is the etiology of acute limb ischemia? What is how the limb ischemia happens? Emboli, very good. Thrombus, very good. So it can be either due to embolic or it can be a thrombotic. What is the difference between embolic and thrombotic and why it is clinically significant?
Embolic is from the distal side.
Yeah.
Side
of the and does it make a difference to know the etiology of acute limb ischemia? It is embolic versus thrombotic.
If there's an embolic thing and go into another place as well.
Very good. One thing. Okay. Any other?
It indicates an underlying disease, for example, embolic type problem,
Heart. Very good. Very good.
It could be deficiency in recovery.
It can be.
If it's getting to lungs, then it can be a deficiency. So we need to look for it.
Yeah. If it is DVT, we are talking about the arterial problem. DVT is a different entity. So it can be an embolus. Embolus is a clot coming from somewhere else and lodging at a normal artery. It is usually lodges at the aortic bifurcation. It lodges at the femoral bifurcation or at the popliteal bifurcation, and patient present with signs and symptoms of acute limb ischemia. Yeah, but the vessel is normal. Suppose if the vessel is diseased like atherosclerosis and then there is an in situ thrombosis, then it is thrombotic. Here the problem is the artery is diseased. Now in embolus the treatment is very simple. You place a catheter, remove the clot or give a medication and it dissolves the clot. But in a thrombotic, if you dissolve the clot or remove the clot but do not treat the underlying artery, it will recur. Yeah. So if you get a thrombotic patient, you have to treat the underlying cause, that is the plaque which is there, which is causing it in situ thrombosis. And that can be done by either angioplasty or stenting or doing a bypass, or I will tell you how to do an endarterectomy. We can treat it up. And how you clinically find that patient is having embolus versus thrombotic? Clinically, it is very simple. For example, in an embolus, the arteries, the patient will have a signs and symptom of atrial fibrillation or any heart problem. And when they present, the limb will be involved, but the other limb pulses will be normal because the pulses were normal. But in most of the patients with a thrombotic, which has acute and chronic thrombosis, they occur in patients who have atherosclerosis. For example, they are diabetic, hypertensive, they have smoker, and now they may present with a history of intermittent claudication. And when they have the symptomatic side, you pulses on other side, the pulses may be feeble because atherosclerosis is a disease vessel. So whenever a patient comes with acute limb ischemia, you have to answer only 3 questions. Number 1, is patient having a pain due to ischemia or something else? Number 2, is it embolic or thrombotic? It is very important to know. Number 3, what is the grade of this ischemia or the class of limb ischemia? Any grading system, classification system you know?
Rutherford.
Yeah, Rutherford. From where you have heard this word?
Sir, last week
So you talked about, okay. So Rutherford classification, you saw a small child with that who presented from Sakhar and he has a discolored limb. So according to Rutherford, we divide the limb ischemia into actually 3 grades. One is viable, two is questionable viability or threatened ischemia, and third is non-viable. So see my hand, it is pink, it moves, it has sensation. When you check pulses, the pulses is there. And if you put a Doppler, there are signals. So this is viable, this is category 1. Suppose there is a limb which is discolored, it has no movements, it has no sensation. You put a Doppler, there is no arterial or venous signal. It is non-viable. And the treatment is amputation for those limbs. In between is a questionable viability. Questionable viability, I will say they are threatened limb. They are further divided into two categories. Immediately threatened and in which you have some time. So we know that in limb there are 4 tissues. There are nerves, there are muscles, there is skin and the bone. The higher the metabolic activity of a tissue, higher it is at risk of developing ischemia. For example, nerves tolerate the ischemia of 2 hours and then they develop an irreversible changes. And it is 6 hours of ischemia when muscles start developing irreversible changes. And it takes about 12 hours to 24 hours for the skin to show their changes. And takes about 48 hours to 72 hours for the bones to become that. So when the skin changes happens, the nerves and the muscle are already gone. It is too late to actually do revascularization and save the limb. And when you see in the clinical practice, the call for a vascular surgeon goes when the skin changes happens. It is the nerves are gone, the muscles are gone. So it means you should have a very high suspicion of limb ischemia whenever patient complain of pain. And it's very simple to diagnose. 5 P's. Is the patient having pain very severe? Is it perishing cold? Is there paresthesia? Is there paralysis? Is there pulselessness? If you check these things, you will easily detect a limb ischemia. But the problem is that most of the patients are not examined and ignored, and then they present late. I go through a clinical history and ask you, if you get a 30 years old lady who presents to emergency room with a severe pain in the right leg for 18 hours, if this present to you and you are the physician there, what do you want to know more about this patient?
Any history of trauma?
Okay, there is no history of trauma.
Was the pain acute onset?
Yeah, pain started, it was first time patient is having this pain and it started suddenly and it is severe in intensity. The patient had a atrial fibrillation for which she was taking anticoagulation.
She took that medication.
She has left it for about 1 month back.
Only recent surgery.
No, there is no recent.
Any history of travel?
No, there is no history of travel. Any other thing you wanted to ask?
Any paralysis, paralysis?
When you examine the patient, you want to examine it now. The pulse, the limb is cold. The pulses are lost from femoral. There is no pulse popliteal, no pulse pedal. There is mild paresthesia of the toes, and there is no paralysis. What is your diagnosis? Huh? What is your diagnosis?
Acute limb ischemia.
Yeah, due to embolus coming from or patient, and patient is there. And how would you manage it? The patient is in the ER, how you are going to manage it up?
Based on the grading.
Yeah, grading. So it is what grade? It is viable, non-viable, questionable viability. Huh? First stage 2A. Yeah, 2A. Okay, how would you manage it up? Very good. Anticoagulation, you will start anticoagulation. Okay, very good.
Revascularization.
Revascular, how you do it?
Stand.
Stand, okay. We'll discuss, okay, what are the options, okay. So, very good, you manage. The first thing is the pain management. So this was the classification I was talking about. You are rightly said it is known as Rutherford classification. in which we divide the limbs into viable, threatened, and irreversible. The threatened is further divided into marginally, and then there is the immediate. So why it is important to divide it up? Because in a marginal, only some of the nerves are involved, and only the numbness is in the toes. You have time to do some form of investigation to identify the site of embolus and to plan the treatment. Whereas in patients who have immediately threatened, they have profound neuromuscular dysfunction, there is severe nerves involvement, and if you lose minutes, the muscle are going to be involved. When muscles are going to be involved, the limb is going to be lost because the function of the limb depends upon nerves and the muscles. And a functionless limb is worse than amputation. So you have no time, you have to quickly take this patient to the emergency theater. So it is just at your level, you should remember that the limbs have to be categorized into viable, questionable viability, and non-viable. Why I say non-viable? It is important because if you do revascularization in these patients, they are going to end up in severe reperfusion injury, and you may lose the patient due to inflammatory process. So these are the patients in which you don't want to do any form of revascularization. You want to avoid it up. So this is the classic picture of a patient who presents with a classic limb ischemia advanced form that is Rutherford class 2B. The foot is going to be dusky, probably the lights is near, and they have a bluish discoloration. But in the form of severe ischemia, they may have fixed staining, they have rigor motors, they have no sensation, and there is no Doppler signal on the handheld Doppler either in the venous or arterial phase. So it is important on a look of examination, even inspection, you can pick up that this patient is having severe form of ischemia and needs some form of reintervention. So immediately when patient comes to ER, the first thing you have to see is to resuscitate the patient. The patient will be in severe pain, put an IV cannula, give analgesia. They will be requiring high dose of analgesia in intravenous form. Take blood sample, CBC, PT, APTT, BU, and creatinine. And I agree with you, you have to give the heparin. This is anticoagulation. Why? You don't want the clot to progress proximally and distally. Yeah? And when it is done, you can actually plan three things. Number one, either you can treat it with surgery. Number two, you can treat it with catheter-directed thrombolysis. And number three, you can treat this patient with the devices which can actually take out or dissolve that clot quickly, which can be known as the pharmacomechanical devices. Yeah? Coming to the surgery, we have a very good, or the standard of care for embolus is doing an embolectomy. And its name is the Fogarty embolectomy catheter. Here, what we do, we take the patient into the OR, we give a small incision. For example, if the patient is presenting with right leg ischemia, give a groin incision, get a control of artery proximally and distally, and then give a systemic heparin, place a clamp, and they give a small nick in the artery, which is known as arterotomy, and then place a balloon catheter, which has a balloon in front of that, cross that lesion, and then gently pull that balloon backward. When it is pulled, it pulls the clot with it, and that is known as the embolectomy. It was invented by Fogarty. Any idea about the Fogarty? So Fogarty was a OR technician, and when he used to scrub with the surgeon, in those days, people used to give a long incision for these clots, long incision. and then open the artery, remove the clot, and then close it up. And that ended up in major morbidity, major blood loss, and longer operative time. He used to catch flying fish in his childhood by a thread at the end of which balloon. He thought, why not I experiment it up? He took a thread and took gloves, simple gloves, make a balloon, small hole in the artery and place it up and pulled it out. And it worked. So he went into medical college. When he was fourth year medical student, he patented this device. And this device has actually saved more lives and limbs than any device in the world. He got Nobel Prize for this. Yeah, he became professor of cardiac and vascular surgeon, and it is his invention which has made it up. Simple solution. Okay? This is known as Fogarty embolectomy catheter, invented by a medical student. Yeah, but sometime you can get a patient who has acute and chronic thrombus. For example, they are atherosclerotic, they have diseased artery, and when they present, they present with a severe form ischemia. Here, as I have told you, the problem is that if you remove the clot, it is going to recur. Why? The artery is diseased. For example, this was a patient who presented with bilateral limb ischemia. It was severe limb ischemia. It was Rutherford class 2B. He was smoker. He was 65 years, and he was diabetic. And we did a CT scan, and it shows that aorta just below the renal artery is totally occluded, and the iliacs are totally occluded. And we know that it was acute and chronic thrombus, means there is atherosclerotic plaque due to his risk factors, and it has got complicated. So if we have done simple embolectomy, it may have removed the clot, but it has recurred. So we thought we should treat it up. So for that, we have the surgical option of getting a bypass, that is using a graft from the aorta, which is normal, and to sewing it off where the artery is normal. This is known as aorto-bi-iliac bypass. But the problem with this bypass is that it is a prosthetic graft. It has risk of infection. So to prevent it, we devised the method which is known as the thrombo-endarterectomy. We have three layers of the blood vessels. There is intima, there is a media, and there is adventitia. The plaque formed between the intima and the media. And if we do a dissection in a plane which is in between the media and adventitia, we can remove the plaque. And this can remove the disease which is causing the thrombus. And this process is known as the endarterectomy. So in this particular patient, what we did, we opened the abdomen from the midline, got a control of dissected the aorta. This is the cranial end, this is the foot end of the patient, and place a retractor, pushing the bowel towards the right side, and then give a longitudinal arterotomy over the aorta, and then endarterectomy, in which we remove the clot from the aorta, right common iliac artery and left common iliac artery. And when it has been removed, the aorta needs to be closed. If we close it primarily, there was a risk of developing stenosis. So to prevent it, we place a patch made of bovine pericardium. This is to prevent the stenosis and rethrombosis. And bovine pericardial patch has been restored. So in this patient who has presented with acute and chronic thrombus, we have not only removed the thrombus, but also removed the underlying cause. Yeah? Any question, any comments on this point? Okay. The other thing which I will say you can use is a catheter-directed thrombolysis. Here what we do, we place a catheter in the thrombus catheter, and it has side holes. We give a tissue plasminogen activator that actually dissolves that clot. But there is always risk that this medicine can go somewhere else and cause bleeding, and they are very slow acting. It takes about 12 hours to 20 hours to work on that. And we need a checked angiogram. For a Rutherford class 2, this is not a good option. But for class 1 or class 2A, it is a good option. It is minimally invasive. You do not need incisions. But in those patients who are having contraindication to like a tissue plasminogen activator or streptokinase, we have devices which are known as the pharmacomechanical devices, in which what we do, we place a catheter and inflate it proximally and distally to the clot, and then actually dissolve that clot or disrupt that clot and then give the medication. That acts quickly because the surface area is quite good, and then it is sucked out. And even there are suction catheters or suction devices which can actually pull it out using without any pharmacological method. But problem of every revascularization is that patient can develop myoglobinuria or they can develop reperfusion injury. Why these patients develop reperfusion injury? Any idea? Very good. So you have to go to little basics. What happens? So if you go to the cell, this is the cell, this is nucleus. The energy out of the cell is the mitochondria. And the oxidative revascularization is happening at the level of the inner membrane. Yeah? And that membrane makes the ATP. When oxygen comes, oxygen jumps from one protein to another. Proteins are sitting like chairs in that inner membrane, and when it jumps, it produces ATP. ATP is required for our sodium-potassium channels. It keeps the sodium out, keep the potassium in. That is the work. Now, suppose you give anoxia, no oxygen to that cell for about 5 hours, 6 hours. Now, the oxidative revascularization will be shifted to anaerobic revascularization. And these proteins will be disrupted. Now, after about 6 to 7 hours of anoxia, you give again, do the revascularization, remove the clot or do some bypass and give oxygen. Now this oxygen reaches again to this cell, but those proteins has been now disrupted. Now what will happen? Sorry, oxygen will not be used, and oxygen will be converted into free oxygen radicals. Now these oxygen radicals will be coming. Now these oxygen radicals will go into the venous circulation and go to the whole body. Wherever the endothelium is there, they are going to damage it up. And they are going to activate the complement system and the whole inflammatory process. They can cause the patient ARDS, they can cause patient renal failure, they can cause patient SARS, and even multi-organ failure. So that happens with the reperfusion injury. To prevent that, you have to identify these patients quickly, you have to hydrate them, and actually do the revascularization as early as possible. Meanwhile, what happens? As soon as you improve the revascularization, now the sodium, instead of going out, is coming inside, and it is causing intracellular swelling. Yeah? And in the cough, we know that there are 4 compartments in the leg between the tibia and fibula. Any idea about the compartments? Any idea about how many compartments are there? 4. And name of the compartment? Anterior, posterior, lateral, medial, there is nothing. So the medially there is, the medial is tibia, this is the fibula. In between there is interosseous membrane, and we have an anterior compartment, then we have a lateral compartment, then the posterior compartment is further divided into superficial posterior and a deep posterior. They are tight osteofacial compartment. When there's a revascularization, the sodium is going to retain into the cells. There's going to be local edema. The pressure is going to be increased. It is going to affect the capillary reperfusion. And the patient is going to develop again the ischemia. Yeah? Even the pulses are palpable, but there will be going to be ischemia. This is known as compartment syndrome. And that happens in patients who present late, who present with severe form of ischemia. And to prevent it, you can do a fasciotomy. What is fasciotomy? It is opening or laying out of these tight compartments. And that can be done by different techniques. There are three methods of doing fasciotomy in the leg. One is known as one incision technique, other is two incision technique. In one incision technique, what we remove this fibula. If we remove this fibula, the anterior, lateral, deep posterior and superficial posterior compartment will be open. But it is quite morbid procedure. So what we do, we use a two incision technique, in which one incision we give between the tibia and the fibula, and that opens the anterior and the lateral compartment. Then we give a one incision just inferior to the medial border of the tibia, and that opens the superficial posterior and deep posterior compartment. Yeah, this is two incision technique. So whenever you think that patient can develop a compartment syndrome, you have to perform a fasciotomy. Fasciotomy is not performed when the compartment syndrome has developed. It is always a prophylactic one. So to prevent that, again, you have to identify these patients early, reperfuse them quite quickly, and if you suspect, do a prophylactic fasciotomy. You can save these limbs. So this was just general overview of a patient who present with acute limb ischemia and how you have to manage it up. So my question to you is that what is a Rutherford class 2 ischemia? Viability and immediately threatened. And what are three methods of revascularization in patient with acute limb ischemia? Embolectomy. Okay. There are surgical methods, two for the acute and chronic, one for embolic. Any other method?
TPA.
TPA. How we give a TPA? Intrathrombotic. This is known as a catheter-directed thrombolysis. CDT, catheter-directed thrombolysis. What we do, if this, for example, if this is the femoral artery, if this is the femoral artery and the clot is here, okay, and this is the popliteal anterior. So we bring a catheter from other side, and this catheter has hole at the end. They have small holes like this. And now you give a bolus of TPA and then give an infusion of TPA over time. This is known as catheter-directed thrombolysis. It dissolves the clot from there. It is slow acting, but it is minimally invasive, very effective method. The other method is the pharmacomechanical, in which, suppose if this is the femoral artery and this is the clot here, we use a device which has balloons here and here. Yeah, it has a catheter which has side holes. Okay, we cross this lesion. When it is crossed, the balloon is going to be inflated like this and this, like this. And now you give a medicine. But the medicine will be still very slow to act. So we will disrupt that plaque by ultrasound or mechanical way and then give the medication. It will work fine. So it can be known as the pharmacomechanical method of thrombolysis. Yeah? What are two complications of acute limb ischemia after revascularization? Yeah? Reperfusion injury, yeah? Now we come to across a totally different situation.